Great, so welcome to our session today. I'm Laura Davidson and I'm the Recruitment Manager for the Masters in Global Healthcare Leadership. And today we're going to be talking about the topic of driving health equity through leadership. Health equity is obviously a huge and very important topic. And today you'll have the chance to hear from some of our brilliant students and faculty members who will be sharing more about their work in this area and how the programme and their learning at Oxford has supported them in making a lasting impact. So thank you so much to everyone for joining and taking the time for the session today. We'll obviously go to full introductions shortly. Before we get started, I want to mention that the session is recorded and a recording will be sent out probably towards the end of next week. For those of you who are joining us live, the Q&A function is up and running, so feel free to post questions and we'll do our best to answer those. And then at the end of the session, I'll also briefly run through the application process for those of you who are looking to apply this year. But to get the session started, I'm going to kick off with some key facts about the programme. So next slide, please. Great. So the Masters in Global Healthcare Leadership is a relatively new programme. It launched in 2022. So we've had 4 cohorts so far. And it's a joint programme, so it's a partnership between the Business School and Nuffield Department of Primary Care Health Sciences, who are a medical science department and who bring a huge amount of experience and knowledge in really key areas like primary care, digital healthcare and health behaviour. And the Business School, of course, have lots of experience in areas like leadership, innovation, strategy and entrepreneurship. So in terms of the structure, as you can see, it's a 2-year part-time programme and it's broken down into 18 months of taught modules. And then you'll have 6 months at the end working on a dissertation. There are 8 modules in total and it's designed for people who are working full-time. So the idea is that you gain the qualification without stopping work or having to move to Oxford or the UK. We have 1 class every year with the next intake starting this coming September. And the fee is just over £65,000. Next slide, please. So just to quickly share a little bit more information on the syllabus and the module dates. If we jump straight to the end of module 8, which is the online module, it doesn't actually start at the end. So that runs concurrently over the 2nd year of the programme in 5 blocks of learning. But as you can see, the in-person modules are spaced about every 8 to 12 weeks. Apart. So you're in Oxford every couple of months, and the rest of the time you're back at home, you're working back at work, and that time is focused on the pre-work, so reading lists and case studies, etc., ahead of each module, and then of course your assessments and the online module as well. So in terms of the commitment, we generally say it's about 10 hours of study time a week. And then if we move to the next slide, I'll just share a little bit more about the typical class profile. So we tend to see about 30 students in the class, so it's a good size. And as you can see, the average age tends to be about 40, but there is a lot of range within this. So we have people in the class who are in their late 20s and early 30s. We have people in their 50s and beyond, and we love having this diversity of experience represented in the class. Female representation this year is comparable across the executive portfolio. It has actually been higher in previous years. I think last year it was 64%. And we tend to have over 20 nationalities represented, so it's a really diverse group, which is obviously really important when discussing global health. And it's an experienced group, so averaging about 15 years of work experience. Again, it's fine if you have more or less than this. And we see lots of different sectors within healthcare. So it's a good mix of physicians and then people working in other areas of healthcare. So things like consulting, finance, technology, pharma, entrepreneurs, which again makes for a really interesting discussion. So if we just go to the next slide, I'm now pleased to hand over to 2 lovely members of faculty who will be leading the next part of the session today. These are 2 people that you'll get to know very well if you join the programme, and they form a really big part of our students' experience, so it's lovely to have them here today. So if it's okay, I'll ask you both to introduce yourselves and say a little bit more about your work before we move on to the wider discussion. So Gugu, over to you.
Thanks, Laura. Hi, everyone. I'm Gugu. I'm a teaching fellow on the Global Healthcare Leadership Program, which means I engage a lot both with the faculty and with the students, sort of as a bridge of sorts. Um, I'm housed in Nuffield Department of Primary Care Health Sciences. My background is in nutrition. I do a lot of work in South Africa, Zimbabwe, and Kenya. Nice to meet you all. Thank you.
Thank you, Google, and welcome also from me. I'm a teaching fellow as well for the program. Google perfectly explained the fact that we work across faculty and students. I look particularly at the student experience, taking care of the academic part of your time with us as students. I'm as well part of the Department of Primary Care, and I teach in a couple of modules, social determinants of health and global health equity. I'm also a life coach, so particularly interested also in leadership. Very happy to be here today, and particularly to have as a panelist the people that you see in the next slide and already joined us here that are students of the present cohort or alumni. If you can move to the next slide, you will see their faces and their profile that as usual is as you see that they are really interesting people, but I feel uh, also, because time is running fast, that we can move immediately and they will have time to introduce themselves in the next half an hour that we will spend together. So thank you for being with us, Hiba, Toshi, and David. Looking forward to this conversation, and Google, why don't you give it a go with the first question?
Thank you. So the first question, of course, is could you please introduce yourselves and tell us about the amazing work you're doing and what inspired you to pursue a career in global healthcare leadership?
Maybe we can ask Toshi to start, and then Hiba, and then David. Is that okay?
Yeah, sure. Hi. Thank you, Laura, Davide, Gugu, for this opportunity to speak at this event, or at least share my perspective. So everyone, my name is Tochi Okwasa. I'm a cardiologist, a professor of cardiology at Rush University Medical Center in Chicago in the United States. And I have clinical work and research work that focuses on cardio-oncology, which is intersection of cardiovascular disease and cancer. Of course, the number one and number two causes of death, both in the United States and in the world overall. I've been involved in building programs and national initiatives that advance the emerging field of cardio-oncology, but I'm particularly interested in how health systems can deliver innovative care more equitably. And that's really a passion of mine and part of the reason why I'm with this program. So I also teach, I'm involved in research and academic publishing, and currently serve as an associate editor for a journal of the American Heart Association.
Thank you. Eva?
Hello, thank you for the invitation. I'm Hiba, founder and CEO of Mirsal Foundation. We are an Egyptian NGO specialized in healthcare. We provide healthcare services for patients, Egyptian and non-Egyptian. Actually, we have now we have patients from more than 60 nationalities in Egypt. And at the beginning, I just wanted to help people to access healthcare, the Egyptian nationalities. And later on, with the wars in the Middle East, I decided to offer and provide health access for all patients. We provide services and we have managed multiple medical centers, pediatric hospital, NICU, dialysis centers. And after 10 years with Marcel, I decided to study global healthcare leadership to have more strategic view for the work, not only the daily tasks.
Thank you so much.
Okay, thank you. First of all, thank you everyone for being here, and especially our faculty for the invitation. I'm very delighted to share the stage with my dear Hiba and also with Dr. Pochi. So my name is David Castellanos. I'm from Honduras. I'm a medical doctor with a master in healthcare management and also the master in global health leadership. I have over 20 years of experience working in the public health in different capacities, but most of it was at USAID during 16 years until its closure last year. So it's precisely that experience in international development in the health sector that inspired me to pursue deeper knowledge and a world-class network to expand my capacities to contribute significantly to initiatives in public health in my country, in the Latin American, the Caribbean region, and beyond, because I think we are in capacity for providing any experience and expertise and knowledge to any settings worldwide as a result of our studies at Oxford. Thank you.
Thank you so much. And then the next question is about equity and how would you define equity? And why do you think, for you personally, why is it such a pressing challenge right now?
Why don't we start again, reverse order, and David, if you want to give an idea of what equity means for you.
Sure. Okay, this is one of the key terms in health. Actually, the World Health Organization defines health equity as a fundamental right and a goal for the public health systems, which it's aiming to eliminate preventable, unfair, and systematic disparities for the population. So I believe that this is a pressing challenge everywhere, not only in low middle income countries, but everywhere in the global north and the global south, as we see disparities across different populations due to social, economical, demographical, or even geographical aspects in their lives. And this limits the capacity of individuals and beyond countries overall to live a healthy life. So that's a big challenge, because we see the world at this moment having a lot of impact in their health systems, and also internationally it's all the turmoil of all these geopolitical actions that are occurring are affecting the lifestyles of everyone everywhere.
Thank you. Hiba, so what is how would you define health equity from your perspective?
I believe that is to have the right access for healthcare, regardless nationality, religion, economic situation, whatever. Any patient should have the chance to be treated, and especially with the hard situation in the Middle East, we can see this with Gaza, with Sudan, with different nationalities. Even they can't reach healthcare access, the minimum of healthcare access. And regardless of the war, even in Egypt, many patients, Egyptian and non-Egyptian, can't access because of money, because of transportation, because brain drain of doctors. So having healthcare equity means you can reach the healthcare without any barriers.
Thank you.
Yeah.
So for me, first of all, I want to just kind of go back a little bit and just say the reason why I decided to do the global health course, I didn't mention that, but the reason is because, as a clinician, I take care of one patient at a time. And at some point, I had to ask myself, especially with when the COVID-19 pandemic hit, and realized that the world is all connected. I'm originally Nigerian, right? And so the ultimate question is, how can we improve population health one way or the other? Taking care of patients, one patient at a time, is important, don't get me wrong, and it's very, very fulfilling for me in what I do, but I needed to figure out a way to have a wider impact. And that was how I sought out the Global Healthcare Leadership Program. And thanks to Laura, I'm basically almost done with the program. Thanks for recruiting me. But in terms of health equity, I think about health equity in terms of outcomes, right? So the general idea is that we have all kinds of marginalized communities, whether it's by race, socioeconomic status, the geography. To me, health equity means that we're saying that regardless of all these factors that affect people in culture, in their own context, that all of these should not be the paramount or the most important factors that lead to outcomes, right? So the general idea is that you're providing healthcare in such a way that it's equitable so that outcomes, if all things were equal, when we're talking about equity, then the outcomes overall should be based on just the amount of healthcare that's delivered, and all these other factors should have no role to play when it comes to individuals and their health. Generally speaking. So when we talk about marginalized communities, I talked about race. They're poorer people, less educated people in the rural communities, and really all over the world, whatever part of the world that you look at, there are life expectancy gaps, right? And when you look into the system to try to figure out those life expectancy gaps, oftentimes it's these other factors that are influencing the life expectancy gaps rather than the healthcare itself, right? So it's really creating healthcare in such a way that you're meeting each of these individuals and each of these populations where they are within their own culture, within their own context, to deliver healthcare in such a way that they feel that it's robust and just about equal for everyone. That's the way I think of healthcare equity.
Wow. Thank you. I think you gave already a very good overview of what global health equity means, right? David, you talk about the overall context and how we aim at something that is defined by WHO, by the international regulation. Hiba, you talk about the working on the ground and trying to face all the challenges that health systems are at the moment having to go through in order to reach equity. And you, Toshi, clearly gave us an overview of how social determinants of health, so all these aspects that are also outside the health systems, needs to be factored in, needs to enter the big debate on what does it mean being equitable in providing healthcare. Healthcare is not a commodity like the other, right? Health is something that is essential for our life and determine massively our well-being. We need to be particularly careful when we shrink our view into something that is just considering one layer or one factor, is multifactorial and is multi-layered. I'm really pleased to have the three of you, exactly, and with the help of Google, trying to unpack your perspective as leaders, starting from your experience. So now we have a bit of time in which I will ask you a bit more about your experience. Please don't be shy, don't be modest. we know you tend to say, yeah, I do my little bit. No, we know you do amazing things. Please use this time to show to the people that are connected how you drive health equity through your job. That potentially for all of us, the perspective is always, yeah, but I just do my part. But you do an amazing part where you are. I start from Hiba. As I said, you are the founder CEO of Mercel's Foundation, and you mentioned that you run different healthcare at different levels in a context where healthcare, providing healthcare can be a bit challenging, right? What is the biggest challenge you are facing at the moment as a leader in driving healthcare equity?
The major challenge is how to balance between the demand for services and the fundraising, especially that we depend on individuals' donors, not the international fund or governmental fund. So we have to collect day by day funds, and how then we allocate them and select the patients who will take the service first, and how some patients their treatment cost is more than $1 million and others needs thousands. So how to choose the patients and how to allocate the money depending on the priorities. At the same time, as I mentioned, with the war in Gaza and Sudan, we have now in Egypt more than 10 million 10 million migrants. And before that, Egypt already is 110 million. So it's a huge population with limited resources, individual donors who their donations can be less because of the economic situation. So we have different challenges to collect the money on individuals, then how to allocate them between the patients. And it's not a secret because of Trump decisions. Also, the international organization cut their budget. So even the funds we got from UNCHR, for example, is now maybe half the amount, the yearly amount. So you have many gaps from the Egyptian economic situation, international decisions, and millions of migrants from Gaza and Sudan.
I can imagine. Big challenge. Prioritization, I think, is one of the topic we discuss a lot during the program, right? Limited constraint, increased demand. This is really a challenging situation that I think in class we set and discuss various frameworks, various approaches that can exist. Can you, Hiba, give us an idea of, with an example or just in general, how you go on with this prioritization, how you manage? Because as you said, one drug of 1 million for a person that really needed, or a service provision for many more people, but that are not a life threat, right? This is the challenge that a leader in healthcare that try to be equitable needs to face, right? How do you face such a
we created different techniques. They are not the final solutions, but it improve the situation. For example, we have partnership with all the pharma companies, so we can get special offers for charity. For example, bonus, take one, buy one and get one. And this with the huge number of medications can save millions. We have also agreement, as I mentioned, with UNCHR for refugees, the Committee of Refugees. So we take fund for some of the refugees, and the rest of them we treat from donations. and who are covered by the governmental insurance, we direct them to the medical insurance. So we try to يعني allocate people to different channels, and we just treat who are not covered by any system. After that, we have the doctors at the beginning of the patient cycle who can classify them and decide who are called blue and who can wait. And depending on this, we allocate the money.
Wow. You see, innovation is another topic that we we explored in our course, and I think innovation is not just introducing a new machine, but is finding ways of prioritizing, reaching out to the people that you think are more in need, using all your diplomacy and tool to obtain from who has economic power or a stake in terms of offering drugs to provide them at a certain cost. So all the tools as a leader require having the big picture. And thank you for sharing with us a bit of what you do on your daily life. I'm sure there will be more time to go back to you, but if it's fine, I now move to Toshi, if it's okay. Why I'm really interested in understanding your perspective as well, Toshi, because you are a professor of medicine and cardiology, so your perspective is more from the a person working on University Medical Center. I just want to understand how, from the job that you do as a cardiologist in a ward, how do you use those tools of being a leader to promote health equity?
Yes. So, the way I think about health equity in my setting, so I'm in Chicago, and as you mentioned, I am a clinician, and also get involved in educating and teaching residents and fellows, and so on. So, I think about cardiovascular disease, number one cause of death in the US, number one cause of death in the world, and something that we've all talked about making some sort of headway in, right? So in Chicago, there's a 20-year life expectancy gap between the north and south side of Chicago. And that is, we all would agree that that is completely unacceptable. My institution is on the west side of Chicago, and it's like right solidly in the middle of the north and west and south side of Chicago. Now, the south side of Chicago is mostly a Black population. The north side of Chicago is mostly a white population. And so you can understand how there are issues and inequities and gaps and problems, mostly related to social determinants of health. Now, when I think about it, I've, had conversations with leaders in policy in the Chicago area. Everybody knowing Chicago as a city would think, okay, it's drugs, it's guns, and so on, and homicide and the rest of them. But what I'm finding out and what the data is suggesting that it's actually cardiovascular disease, right? Which is right up my alley. That's what I do. That is one of the major drivers. I'm not saying that the social determinants of health that we talked about are not involved. They are heavily involved, and that's an issue because even then, those social determinants of health also drive the cardiovascular disease to begin with. So, in my opinion, it's important to educate. It's important to harness, we as physicians, we as clinicians, we as healthcare providers have a lot of agency. And I think we have more agency than we know. So in my opinion, it's educating the younger generation, the younger physicians, the younger clinicians that are coming up, not just in how to manage, cholesterol and heart attacks and heart failure and the rest of them, which obviously is the bane of cardiovascular disease. And I think it's important. It's important to educate them to think beyond all of that, right? What are the systemic forces that are driving all of the issues that we're seeing? What are the systemic forces that are driving the disparities that we're seeing? How can we handle those systemic forces? How can we actually leverage the skills that we have, the agency that we have as clinicians to actually make a difference in such a way that we impact our patients, in such a way that we impact our population? So that, to me, is one of the things that's extremely important. In my role as a cardio-oncology specialist, right? So kind of bridging heart disease and cancer, one of the things that I found out was that we had a paucity of cardio-oncology specialists, so people that understand cardiovascular disease amongst cancer patients. We have, Chicago is made up of 8 different academic centers. So it's a huge academic institution. But what about those patients that get their treatment and then they go out into the community, right? To continue their treatment or just as cancer survivors. And you have all these other physicians, cardiologists, primary care doctors, oncologists that don't really understand that cardiovascular disease is the #1 cause of death amongst cancer patients, right? Other than the cancer itself. And so educating them has been important to me. And so one of the things I did was I founded what we call the Chicago Citywide Cardio-Oncology Rounds, where we have these rounds every quarter and we educate the physicians, the clinicians, the nurse practitioners, the nurses, the medical students, the fellows, and so on and so forth. And the general idea is to empower these physicians that are out in the community that are caring for these cancer patients that are survivors so that they're better able to care, so that they know the sorts of issues to think about and they can manage their health. So regardless of how you look at it, I think, again, education, helping the population of clinicians that are caring for patients to think beyond just managing disease processes and rather to think about how to systemically think about disease. And again, there are administrators, there are policymakers, there are a whole bunch of different sorts of stakeholders that can be brought to the table to have these conversations that again, we have equity in mind and we're thinking about how to harness all of the different stakeholders, how to harness all of the different stakeholders and where they stand in terms of informing systems to be able to make a difference and have impact. So it's, again, education and training, I think is part of the main key.
Thank you. Thank you very much. I think this combines and completes very much the perspective that Hiva gave, right? Funder, CEO, coordinating hospital, but then, and that is a way of being leader promoting. But then, in your case, Chicago, as cardiologists, looking at the needs of the people you have around, the environment you live in, and really living your leadership, making an impact. I thank you for clarifying also that it's not just a matter of north-south of the world, but there is a north and a south in terms of global health equity, even in a small geographical area like a city, right? And I think, and we discussed this during the course as well, Toshi, how much then you can break it down, because you look at the perspective, for example, of cardiovascular disease, but then there will be a different north and south if we consider other disease. And that is really important message and something that you, as a leader, you have very clear in mind. And that is a very important part. But what remains with me a lot is the fact that you make your leadership a tool to transform education into agency. And agency is the key element if we want to shift the needle in terms of equity, right? Otherwise, we go back to patterns that are always those ones, right? We need people that shift the perception of agency that they have. As you said, patients or young students or your colleagues, they need to be aware that they can make the difference, and only leaders can give them the feeling that they have this agency, and they can point at them, look at here, you can decide if go this direction, this is towards equity, and this is not, right? So thank you very much for giving us this example that is really, really complementing what Hiva was saying. Now, again, I want to hear more from you, but we give David a bit of space. Thank you again. But um, David, you mentioned already you were working for big international agency that then were um, change their nature. You then was affected by the recent reorganization of funding in the global health space, and you founder executive director now of Biolumis, right? Uh, you have a privileged point of observation. What is your opinion on the impact that had on health equity, what you have seen and the challenges, and what do you think are the opportunities in these new circumstances for global health equity?
Oh, that's that's a difficult question
It is.
because obviously the world has seen an unprecedented decision on the global health sector, especially when the United States government decided to cut the funding, and not only funding, but the membership from the World Health Organization and from other international organizations that work in the health sector. And that has shocked the world and the countries that had bilateral and multilateral agreements to providing healthcare to millions of people. And obviously that deepened the health inequalities in some scenarios because we saw maternal child health programs, HIV prevention programs, nutrition and food security, just to mention some of them, affected directly from this decision. And this is across the world, in Latin America, in Asia, in Africa. And from what I heard from Dr. Toshi, I think it's the same thing in other communities within large developed countries, especially in the United States. So I believe that this is the challenge, that at this moment, when the decision came, the countries were not ready at all for making a transition overnight from having a dependency on some of their vital and critical programs to deliver life-saving healthcare to the people. So that have shifted the point of view from everyone. Right now, the countries need to prioritize on these programs and allocate their investments so that they can continue providing this life-saving healthcare to the population. And on the other sense, we have the international agencies that have been working in the past with more resources available to shift their focus on a more efficient implementation so that they can achieve the goals with less resources. So that's one of the biggest challenges. But within the challenges, we know that in the middle of crisis, they come great opportunities, especially for innovation. And that's where leaders need to step up and provide some solutions. So for me, that was one of my motivations for establishing this consultancy firm, because there are thousands of people out there that their work was terminated, and they are high quality leaders in not only health, but all the development sector. So I believe that this is an opportunity to provide from our own perspectives and from in our own settings and regions some solutions that are backed up because of our experience, because of our education, and this is somehow, I think, an opportunity to make it more local, so that we are not dependable of international development only, but it's an opportunity for growth for the country, especially in the low middle income countries. So the new architecture of the global health system is on the review. We know that I've been participating in a Wellcome Trust initiative to make a proposal globally, and I participated on the Latin American and Caribbean region discussions, which it came very interesting of how we need to approach this new scenario. You know, this was one of the things that I learned precisely was ghost scenarios that, you know, it shows up when you never are prepared and it haunts you when it happens, like the COVID-19 pandemic and now this decision, which is kind of a high impact in the health system globally. So I believe that health equity needs to be one of the focus for the interventions in the future and starting right now as fast as we can in everywhere in the world.
Thank you. Thank you very much again to bring another perspective in. And I feel that trying to look at the opportunities that are coming in this constantly changing world and global health world is a job that leaders that needs to always trying to play, right? Flexibility, adaptability is what we always trying to promote while we sit together during the course, and I think it comes also from the fact that you well said you change your job throughout this the experience of the 2 years we spent together, but also other people comes in with other perspective. I fully agree with you with the fact that if there will be a time, and there is a time in which we have to lick our wounds, but there is also time of reflection in which we can think of what is the right level we need to promote equity, right? There is an international framework that needs to exist, but there is also a level that potentially is the one you are working with, that is the one of the local leaders that needs to be advised on how to support a transition to health systems that are more independent and therefore more able to look at the real needs, right, of the group of people, of the population that they have to serve, right? That maybe at the global level, this is more challenging, right? Because diversity is one for sure, very, very present in the global health space, right? So thank you for bringing in this perspective. I think Google has a couple of extra questions, if I may send back the ball on her.
Thank you. Okay, thank you so much. I can see I have my eye on the time, but I do have two more questions. The first one is just from your experience, you're all leading in very different contexts, very different settings. But is there a leadership challenge or something you've come across in your work as a leader that you feel being a part of MGHL has helped you either navigate differently or approach from a different angle that you might otherwise not have taken? And Toshi, would you like to start?
You're
You're
muted.
on mute.
Thank you. So I feel that leadership challenge, I think, generally speaking in healthcare, where I am as a clinician and research and the work I do, education and the rest of them, the way I've worked as a physician up until now is there's a problem with a patient, with the system or whatever, we figure out ways to kind of sidestep it, right? Sort of band-aid or temporary solutions, which are not sustainable. I think that some of the problems and what I'm thinking about in terms of tackling problems now and thinking differently now is how to figure out, just like Davida said earlier, the iceberg model, right? Figure out the solution, dig deeper to figure out the root causes of those problems, and then figure out a solution that can be more sustainable. Because if you're able to really get to the root cause, then you're taking care of the problem from the roots, and then you have more sustainable solutions. So those are the sort of challenges that I'm working on. And then when we're talking about bringing stakeholders to the table, focusing on the common goal. What is our common goal, right? In this situation where stakeholders from all over, and our common goal is talking about health equity. So if you figure out the common goal, then you can then meet each of those stakeholders where they are so that they see how they can gain respectful to that common goal. And then we're able to kind of achieve the big picture of what we're trying to achieve.
Thank you
And
so
I'm
much.
mindful of the time too, so I'm trying not to talk.
David.
Well, I think that personally, this is a big moment of challenge because I had a career on international development and I was leading a team. And so I think the challenge right now is for not only for me, but a lot of global health leaders is to remain relevant because we had a lot of networks influencing the government because of our technical expertise and also obviously for the funding that we were bringing to the table. But I think that's where the challenge remains for leaders is to remain relevant at a moment of crisis and to be able to influence smart decisions with the proper information and recommendations for the priorities that the country has. For example, at this moment, my country just have a new office taken in place. A new president came in, and he decided not to appoint a minister of health. He said, "I'm going to be the minister." So that's a huge change. And then how do you influence a president directly, right? And fortunately, I got enough connections to get in touch and try to, make recommendations that will impact the population at its best. For example, in reducing the waiting list for surgery, and also for improving the access to medicines that basically these are management issues. Is they are not because of the lack of resources. Sometimes it's more how do you manage the system. So that kind of thing is for me one of the challenges that are currently happening, but not only in my level in the country, but globally, because you have many people getting terminated in WHO, the Pan American Health Organization. You know what is going on right now in the world. So I think that's one of the challenges. But beyond just this situation is you need, again, I think you need to bring on innovative solutions so you also be enough relevant to make an influence on the global health sector.
Thank you so much for that. Heba. You are on mute.
For me,
The
the
biggest
main
healthcare challenge.
Okay. Before I went to Oxford, I spent 2 years looking for a program that can match with my needs. And alhamdulillah, finally I found it in Oxford. And I believe the main challenge was that totally involved in the daily tasks. And but I didn't have the leadership perspective and how to look through frameworks, not only on very small daily tasks. And this was the main lesson from Oxford. And how I look now for the challenges, we don't know what will happen in the Middle East currently. So I try to have innovative solutions for the next phase and to look from a wide perspective.
Thank you so much. David, you want to chime in?
What do you think if we ask? There are a few questions from the 2 questions from the people online, and I think the first is relevant for Heba, and the second, if David is okay, I will ask Toshi to give a feedback, but you chip in any moment, David. Okay, so the first question for you, Heba, is does you face challenging similar challenges for both private and public health system in Egypt? How does this work? I can imagine resources may be scarce during wartime for both.
Okay. More than 60% of Egyptians take medications from their own pocket. This is very high percentage, but even the 60% from donation, most of them from donations. So our main challenge and focus and how to cover this huge percentage from donation, especially with refugees, and migrants. The private sector still have its problems, but because of money, we focus more with providing donations and providing treatments from charities more than solving the private sector problems.
Thank you, Laura, for the very interesting question, and Hiba for the feedback. Very interesting and complex world. Edwin is asking, in low and middle income countries, focusing on communicable disease control is more cost effective and equitable than prioritizing no communicable diseases. Despite the fact that cardiovascular disease are a leading cause of death worldwide, and evidence for socioeconomic intervention addressing chronic disease is limited. What are your views on these? Toshi.
Yeah, so that's a good question. So I think that when you're talking about the equitable distribution of care, right? You're talking about communicable diseases, but then that means you also have to think about non-communicable diseases if you're talking about equitable distribution of care. And I will tell you one thing, right? If you're talking about cardiovascular disease as the #1 cause of death worldwide, there is a pivotal cardiovascular risk factor that is the most important modifiable risk factor for cardiovascular disease, which is again the leading cause of death, right? And that is hypertension. So if you think about it, it's actually, when somebody says hypertension, it's kind of like, oh, just blood pressure. It's not a big deal. But honestly, it's amazing. And all the studies have shown this, that if you can figure out a way to control blood pressure in a population, you would actually dramatically reduce cardiovascular disease. So whether you're talking about ischemic heart disease, you're talking about stroke, you're talking about heart attacks, you're talking about kidney disease, all of them, if you can reduce, and heart failure, let's not forget that, if you can reduce hypertension, you would make a huge difference. And so thinking about it, hypertension is not, it doesn't seem like such a difficult, it seems like a low-hanging fruit or something that we can do. I remember there was a study I was reading once, a study from China, and I'll be very brief about this, a study from China that looked at that actually evaluated children. There were kids in middle school, so these were kids from 4th grade, 5th grade, that sort of thing. And they divided them into two groups. One group got very, very focused education on diet as a way to control blood pressure. And the other group, they just kind of give them educational material, generally speaking. And after a year, they went back and looked at information, and they found that the kids that had intense education had lower sodium in their urine. Their parents and other adults living in their homes had lower sodium in their urine and had lower blood pressures, right? So think about that. Just really simple interventions that are very, very cost effective can make a huge difference. So something as simple as addressing sodium, something as simple as educating young kids so that they can then influence, like I was talking about agency, giving them agency to influence adults, influence other people within their community. Something that simple is cost effective and will not make that much of a dent in any government's pockets to improve hypertension, which can then improve cardiovascular disease and mortality. So it's really simpler than a lot of us think.
Thank you very much, all of you, for your insight, the feedback to the question. I think, thank you, Winfred, for your question. We'll see if we manage to type an answer, but I think now is time for Laura to give us some additional insight on how to be part of this amazing network of people.
Thank you. Yeah, we are coming to the end, and I know, having just an hour to discuss this together is very, very tricky. But I think, you guys have done a great job, and I continue to be blown away by all the amazing work that you're all doing. Really proud of all of our students here. So thank you so much for coming and sharing that with everyone today. I will just be very brief about the information here, because obviously you're very welcome just to get in touch with me, and a lot of this information is available on our website too. But just to mention that if you are hoping to join the class in September, there's still a good amount of time. We have 3 remaining deadlines ahead. You can see here what you need to have. So I won't go through it a huge amount. If you have any questions about the English language proficiency, please speak to me. I know sometimes people, aren't sure if they need to submit a waiver, but essentially if you use English in your role frequently, or if you did a degree that was taught in English, you can submit a waiver rather than doing a test like an IELTS. And then, as you can see, we need to have your up-to-date CV, academic transcripts, which is the breakdown of marks and modules for every degree that you list on your CV. So sometimes it takes a little bit of effort, maybe, to get those from your university. At least 2 references. Most people use, just 2. And then there are 3 written tasks. 2 are 500 words and 1 is a 1,500 word academic essay. You can find lots more information on our website. So I'll just briefly mention it. Stage 2 would be a short online interview, which is 30 minutes, and we'll obviously share more information if you get to that stage. And then if we just go to the next slide, just to say, in terms of moving forward, feel free, my contact details are here. You can request a meeting with me, share your CV. I'll be happy to provide feedback, one-to-one if you have any questions on your eligibility, or you want to, chat more. Really nice to set up a call and I can answer any questions that you have. If we've already spoken, or if you're ready just to jump in and make a start with the application, you can do so online. There's a link on our website. A reminder, the next application round deadline closes on the 23rd of March. That's the final opportunity to apply for a scholarship as well. So if you want to be considered for a scholarship for 2026, you need to apply by the 23rd of March. And yes, that is it. If we go to the final slide, bang on time. Just to say thank you so much to everyone for taking the time. Thank you to the audience for joining, but thank you so much to our panel who've been amazing. It's lovely to get yours together, and look forward to hopefully seeing you in Oxford soon when you all graduate. And thank you so much to Davide and Gugu, of course, for hosting a brilliant conversation. And we hope to see people in Oxford, and thanks again. So take care, everybody.
I think.
Thank you.
Thank you.